I've been experiencing lower back pain and general back pain for about 20 years or so. Started lifting when I was quite young, so I've been lifting weights pretty much at least half of my life. It's also the industry that I work in. I spend most of my days moving and lifting around weights whilst training for myself. I experience back pain if I stand for a long time. If I'm lying down for too long, I can also experience back pain. I sometimes get some spasms, so this will probably put me out for a week or so if I've been lifting or continuous lifting or cumulative amount of a lot of lifting in a short period of time.
Tell me about what you understand of the postural important. How does your neck affect this? How does your hips affect this? How does your knee, does your feet play into this?
Well, I know in this day and age, we spend too much time sitting down. We spend a lot of time on our phones. So I know my neck is never in an optimum position because I'm always looking at my phone, checking emails, and a lot of work is done through my phone. Also, sitting in different positions, spending a lot of time sedentary, sitting down when I'm doing admin work, and all of this causes problems I can feel with my spine, positions that I'm in that are uncomfortable for me and lead to a lot of pain and discomfort.
So this is where most people would not expect that somebody as fit as this gentleman getting pains and problems. But if the mechanical chain is not right, and in this case the gentleman has what is called overpronation from his feet. His feet are really falling in. That means that his knees are going in and puts an enormous amount of pressure on his hips. When he makes all these big heavy lifts for himself and with his clients, that therefore puts an incorrect force all the way up from the feet, knees, and to the hip. At the same time, he runs his own business and he's using his mobile all day long to send emails and book appointments, etc. We know that he has got wear and tear in the neck. He's got extra bone formation around the C5 and C6 vertebral bodies, which is the body's way of reacting to an ongoing stress. So you're going to see now how we adjust this gentleman. Take a big breath in for me, and out. Good. Turn to your back for me, please. Lie on this side, please. Face me over here. And come over here with that leg. That leg locking there. Take a big breath in and out. Good. Over to the other side for me, please. And again, big breath in, all the way out. Good. Onto your back again, and come down this way. Thank you. This hand goes in behind your neck here. Roll you over. Now we're gonna get your rib cage moving here and relax. Big breath in and out. Forward all day long. We are now starting to open up.
A lot of clicking.
Here again. Big breath in for me and out, and just let go there. There we go. Good. Just relax in that position. So you can see here, this is where your midfoot is really dropped, right? And that is where we've been talking about how your shoes are wearing, because you're dropping your arches so bad. So here we go. Good. And this then, as we discussed, affect the mobility of the hips, right? Because you get the wrong signals coming up through the kinematic chain, and then you become extremely stiff in your hips. Big breath in and out. And again, big breath in and out. And breathe in for me there, and out. And again, big breath in and out. Good. Okay, let's go up and get you into traction.
On your right side.
My right side. Where do you want my hips?
Hips here.
Hips
and
there.
Shoulder here. This way, yeah.
Yep.
So we are supporting his pelvic. We are creating a drop in the setup of the D-roll table so that his own body weight gravity drops the spine down to the side. So the spine is dropping down away from the incorrect spinal palpation. We are then getting him stabilized so that he doesn't move during the procedure. We have now got him sitting laterally in a straight position. And what is called the 3D arm is now being put into position so we can start tractioning his lumbar spine in one direction while the thoracic spine is dropping into another. So this is exactly the opposite of what his spine is doing. So the spine is going the opposite direction of, you see these forces that we are applying. Since this is early on in the gentleman's traction, we only do this a couple of minutes. But as the patient have had more adjustments and more traction, we slowly increase the length of the traction. So the concept is simple: force over time. The more force we can put over time, the better we are at changing the posture. The patient is then given home exercises where he's doing the same thing as home, but with obviously much less force, and that way he maintains the improvement that he's getting for each adjusting and traction session. Now we're gonna focus on the gentleman's forward head carriage, where he's lost the optimal cervical curve, the neck curve, and where he has got the extra bone formation, the osteophytes between C5 and 6. So First, we're stabilizing the gentleman, and then you will see that we are putting a fulcrum around his neck to pull him forward, and we will be pulling the head back. So we are creating a backwards pull at the same time as we are creating that curvature in the neck. But in order to do that, he has to be stabilized first. So we have the pelvic stabilization, we have the thoracic stabilization. We are now making sure his thoracic spine is sitting in the correct position. He's now getting the pull put onto his neck so we can create a forward force to work on that cervical curve. His head is now being stabilized into the harness. He's being pulled back so we create the curve. And a gentle force is being put onto the head. It's important here that we obviously keep the head in its right position all the time. And then slowly, he gets loaded. Right? Good. And again, we start up with a couple of minutes, and then we build the patient up slowly. The patients are sitting when we do this, having a timer where they can follow their own time constantly and see where we are in the process. So there is a couple of variables here: the time, the amount of weight, and the angulation of the pull. And it's all individual to every single patient depending on their particular complaint. Here we're looking at the gentleman's gait, and we know his feet are falling in. He has got what is called overpronation, and at the moment he's wearing a very, very strong pair of shoes that are supporting him nicely at the medial aspect on the inside, but in a moment you will see him barefoot, and you will see how the feet are really, really falling in and how that has a mechanical effect all the way up. Now, without shoes, you can really see how the feet are falling in and how it's creating tension up to the Achilles because of that rotation. And it's the midfoot particular that is falling in, and it's staying in through the entire gait cycle. It doesn't recover. It's normal to have pronation when you walk, but when the foot stays down and doesn't come up, that's when we start having a problem. In this gentleman's case, it's far more pronounced on the left side, and if you listen when he walks, you can actually hear that he comes down harder on the left side. You can hear that the cadence of walking, there's more pressure on his left side. What you're seeing in this gentleman is we've started the care, we're adjusting, we're doing traction, and now we're looked at the feet in detail. So the long-term management here is obviously to get the gentleman out of his 20 years of back pain, back spasms. He wants to carry on with the lifestyle, which I'm 100% happy with, but we have to support that lifestyle to make sure that he always wears the right footwear, that we build orthotics for the gentleman that is so shock absorptive and guides the foot in the right direction, and it helps to take the pressure off the knees, hip and spine. Then there will be exercises at home that goes hand in hand with the adjustment and the traction in-house. We start off this gentleman with a 6 weeks treatment protocol where he has 2 adjustments a week for 6 weeks, and then we do a re-examination to quantify the improvement, and based on that re-examination we decide where we go from there. When we do the re-examination, we base it on several factors. One, how is the patient feeling? How much better are they? How much has the mobility improved? And we then do before and after posture photographs to evaluate the postural improvement.